Thank you. So I think that everyone knows is know that DCB and DS can be used, in peripheral arterial disease, and but there are some limitations for both technologies, and obviously for DCB, especially long lesion or calcified lesion can be something that we have to consider. But we can solve this problem when we combine a DCB with a spot stenting, because this gives you the possibility to increase the scaffold of the vessel, so increase the patency rate. This is just is an evaluation of the different sub-analysis or subgroups of the impact global registry. What is very important to evaluate that increasing the length, increase also this there is a relation with the percentage of provisional stenting. So we know that lesion length is something that we have to consider that maybe the balloon itself is not able to manage. However, if we consider the two technologies, DS versus the combination of a DCB plus bare metal stent, we have to look to some disadvantages. And you see all of them are more focused for the stent, because obviously we have to consider long metallic struts that we deploy into the vessel, higher risk of fracture, and also we cannot use in what we consider not a good stent zone. On the opposite, if we analyze the advantages, obviously there are some advantages for the drug-eluting stent, just because we have a prolonged drug release. But we have some advantages for the combined treatment, because we can use a small and short stent that we know it is generally related with a better patency rate. However, we think that this is a very interesting paper. This was published this year. 25 trials is a meta-analysis, more than 2,800 patients, where they compare drug-eluting stent versus drug-coated balloon. We heard from Eric there are a lot of studies supporting the use of drug-eluting stents, but look at this. They report a poor risk of restenosis, amputation rate, and thrombosis equal. There are no differences between the two devices. There are a small difference for primary patency and TLR, just because this is related to the age of the patient and also for diabetes. So finally, both techniques are working pretty well. This was the first study that was published back in 2018 regarding the combination of drug-coated balloon plus a bare metal stent. And they reported a 1-year primary patency of 94% that dropped a little bit after 2 years of 88%. And look at the lesion length. It was 20 centimeter mean lesion length. So something pretty long that can be managed with the combined therapy. Again, the impact global. This is real world. They were perform a sub-analysis of DCB, the impact admiral alone versus impact plus bare metal stent. If you analyze the conclusion, according to the author, there is no differences in terms of outcome when you use a DCB, the impact admiral versus the combined therapy. But there are differences in terms of lesion characteristics, because you see that in the stent group, we have the worst condition in terms of calcification, occlusion, and lesion length. And remember that this trial was designed not to compare a drug-coated balloon versus the combined therapy, but the stent were used just as a bailout stenting, where there was not a successful treatment by the drug-coated balloon. And you see, finally, the freedom from clinical-driven TLR was very, very similar, but consider the most complex situation. This is also the analysis of the XL PAD registry. It's a multi-center where they use Lautonics drug-coated balloon or the impact plus bare metal stent, drug-eluting stent, interwoven stent, and cover stent. And finally, they reported obviously that in the stent group there is a more complex situation, but the TLR, the 1 year, was much better, a little bit better, when they combined the drug-coated balloon plus stent. One of the key points is to understand the spot stenting, because obviously if we do a drug-coated balloon and a provisional stenting, we fix all the lesion. This makes not a big sense. You can use directly a stent. But a spot stenting is just to deploy the stent in a specific area where maybe we were not able to achieve the optimal outcome because there is a residual stenosis or a flow-limiting dissection. It's very important the length of the stent, because From this analysis, they compare spot stenting versus long stenting with a mean lesion length of 25 centimeters. And you can see here in terms of primary patency and freedom from TLR that when you use a short stent, you can achieve a better result. Easy to understand because we know that full metal jacket is no more working. So this tests again the concept that drug-coated balloon could be fine to deploy the drug, and then we can use a short stent to increase the scaffold or the vessel. Another option, we can combine a drug-coated balloon with also a drug-eluting stent. This was our experience. It was the first one that was reported. A small group of patients. It was a pilot study, 15 patients. And you see that we combined the Impact Admiral plus the Silver PTX. The two devices with the highest dose of drug that, it's still debate. And you see the primary patency was 1 year 93%, 2 years 92.9%, with a mean lesion length of 14 centimeters, and no local or complex or complication related to the use of a high dose of paclitaxel. Just to show you a case, occlusion, the FemPop region on the right side, we did a pre-deal with an Admiral balloon and then impact balloon for 3 minutes inflation. Still not an ideal outcome in the proximal region. We did a post-dilatation. There was not an improvement. So finally, we deploy a Silver PTX, 6 millimeter in diameter. And this was, the final outcome with a patent vessel under IVUS. And this is the final results 2 years later under ultrasound duplex with a patent vessel. There is something more. Very recently, a Chinese group of physicians reported the use of a combination of drug-eluting balloon plus a drug-eluting stent for task CAD lesion, 32 patients. This was based by the Orchid drug-coated balloon plus the Luvia versus the use of a regular balloon. And you see here in terms of primary patency, 1 year, there is a better performance. That was a little bit strange because after 2 years, this changed a little bit the curves, but the authors do not explain the reason. But again, also for freedom from clinical driven TLR, you see much better double dose. Finally, Eric was also the first author of this paper. They evaluated 22 patients combining the Stellarex and the Impact DCB plus the Eluvia stent. And this is very interesting in terms of freedom from TLR, especially because if you check to the line and the results, you see that there is a little bit of drop after 1 year, but then it's a flat line. And you see that the freedom is 1 year, 2 years, the same data, 84.8%. So in conclusion, we can affirm that the combination of DCB plus spot stenting is very useful, especially in complex situations where we are not able to deploy a long drug-eluting stent. This gave a lot of advantages, especially in that area where we are not able to deploy the stent. But what is important, that you pick one or either other technology according to the lesion characteristics. Thank you for your attention.